Hi, I'm Sandip Patel, a professor in medical oncology at the University of California, San Diego Moores Cancer Center. I discussed updates from ASCO in non-small cell lung cancer in terms of localized disease. One of the areas we've had a great improvement in outcomes for cancer survival overall has been in non-small cell lung cancer, and this has historically been driven by improvements in metastatic disease. However, more recently, the use of both targeted therapy as well as immunotherapy in either the neoadjuvant or adjuvant settings for non-small cell lung cancer have the potential to transform localized non-small cell lung cancer and enhance our ability to cure more patients with localized disease. One key aspect is early detection of cancer through low-dose CT for appropriate patients, which is as powerful a tool as mammography, colonoscopy, and other cancer preventive techniques. I discussed multiple abstracts that related to neoadjuvant, for example, sintilimab and chemotherapy, with approximately 5% improvement in pathologic complete response rate with use of 3 cycles of sintilimab compared to 2, which is similar to what's used in the CheckMate 816 regimen with 3 cycles of chemotherapy plus nivolumab. We also looked at daily versus BID radiation for small cell lung cancer, showing that broadly daily tends to be more operationally feasible with limited impact on quality of life. We also discussed the PEARL study, which is the use of adjuvant pembrolizumab after resection and chemotherapy, and discussed some of the nuances related to PD-L1 testing in strata, as well as efficacy in each of those strata and potential opportunities for patients. And so broadly, we have a multitude of options to help our patients with localized non-small cell lung cancer, utilizing agents we've used in the metastatic setting, with the goal of improving potential cure rates for these patients. But fundamentally, the only way for these patients to benefit is to make the diagnosis early, and low-dose CT screening is the best tool we have for that. One abstract that informs a new practice that many have adopted in localized non-small cell lung cancer relates to the use of neoadjuvant chemoimmunotherapy, in particular the CheckMate 816 regimen, which is 3 cycles of chemotherapy plus nivolumab prior to surgery. There's been some question on what the optimal number of preoperative chemoimmunotherapy cycles would be, and one of the abstracts we discussed was looking at chemotherapy plus sintilimab with a randomization for 2 to 3 cycles with an approximately 5% improvement in pathologic complete response rates with the use of 3 cycles of chemoimmunotherapy. This is similar to some of the data we've seen in higher stage, for example, stage 3A disease with Nadim, and so represents a paradigm reinforcement around 3 cycles of chemoimmunotherapy, at least at the current time, being the optimal number as we wait for readouts from additional studies, for example, such as Aegean. But at the current time, it appears that 3 is the magic number of cycles for chemoimmunotherapy prior to surgery in those patient populations one would consider neoadjuvant chemoimmunotherapy. In our practice, when we're thinking about adjuvant versus neoadjuvant approaches, if we have an opportunity for neoadjuvant therapy in the sense that surgery hasn't happened, we typically will test for EGFR and PD-L1 to help us determine which patient populations may benefit from a more neoadjuvant strategy, for example, patients who are EGFR wild type and PD-L1 negative, versus those patients that may benefit from a more adjuvant strategy, for example, those patients with an EGFR exon 19 or L858R mutation who may benefit from osimertinib after surgery and chemotherapy, or atezolizumab, which has particular benefit in EGFR wild type PD-L in greater than 50% patients, but also efficacy in the 1 to 49% patient population, though that's a subset of patients where neoadjuvant chemoimmunotherapy may be appropriate as well. And so we have a multitude of options that'll benefit patients in the curative intent setting, but we don't yet have overall survival data, but very compelling surrogate survival data to help inform decision making for our patients. But the key concept being the best way to make sure we can utilize these tools is to detect these cancers earlier with low-dose CT screening, similar to how we detect breast cancer with mammography or colon cancer with colonoscopy.